I will discuss in the next 45 minutes the appearance of normal bone marrow and bone marrow disorders. So the principal constituents of bone marrow are the mineralized osseous matrix, the hematopoietic red marrow, and the fatty marrow. The mineralized osseous matrix does not contribute significantly to the single intensity of the marrow. So even in patients who are osteopenic, we should not see an alteration in the single intensity of the bone marrow. Red marrow is most abundant at birth and decreases progressively until we reach a pattern of an adult pattern of red marrow. Children have more red marrow than adults. About 60% of their marrow is red, whereas in adults it's about 30%. So the appearance of marrow on MRI will depend on the relative proportions of red marrow and fatty marrow that we have. So both the red and the fatty marrow contain water, protein, and fat. However, red marrow has much more water and protein compared to fatty marrow, and about half of the fat of fatty marrow. Also, the red marrow in children is more cellular than the red marrow in adults. So the appearance of the red marrow in children will be slightly different in comparison with adults. The marrow will tend to have a slightly lower T1 signal, a slightly brighter T2 signal, and will also tend to enhance more. So when looking at the bone marrow, before deciding if it's normal or abnormal, you have to consider the location in the bone, whether it's an epiphysis, a diaphysis, or a metaphysis. You have to look at the single intensity and compare it to the adjacent muscle and the morphology also, and consider the age of the patient. So bone marrow at birth is completely red, but soon after birth there is a conversion to fatty marrow that occurs in a very predictable way. So first the epiphysis becomes fatty, and then the diaphysis, and finally we have the distal metaphysis that will become more fatty to reach an adult pattern by the mid-20s. However, this process is reversible, and the reversal will also occur in a very predictable way. These are two examples of normal marrow. The first image is a coronal T1 in an infant, so all the marrow is red with a low T1 signal, and at 5 years old you see that the epiphyses are completely fatty. This is normal. So in the adult pattern of red marrow is below the elbows and the knees, the marrow should be fatty. The red marrow persists in the skull, in the spine, in the ribs, in the pelvis, and the proximal metaphysis of the femurs. The single intensity of normal marrow, well, the fatty marrow, it's easy. It will be a bright T1 signal, which will become dark on the T2 fat-sat sequences or the stir sequences, whereas the hematopoietic marrow, we like to compare it to the adjacent muscle. So compared to muscle, it should be iso-intense or slightly brighter than the muscle. And if we don't have muscle in the spine, we can compare it to a normal disc. So it should be brighter than a normal disc. On T2, it should follow the single intensity of the muscle, so pretty much iso-intense to the muscle, except in children, as I mentioned before, in children, because it's more cellular, you can have a slightly brighter T2 signal of their normal red marrow. So this is an example, normal marrow in a 12-year-old. So the epiphyses here are completely fatty. This is normal. And you notice the slightly grayer appearance of the distal metaphysis because there is some red marrow, which becomes more evident on the fluid-sensitive sequence, where you can see it's even slightly brighter than the adjacent muscle because it's more cellular when you compare it to an adult red marrow. Now, this is also a normal example of marrow in a 16-year-old boy, and you see again the epiphysis completely fatty on the T1, suppresses homogeneously on the T2 fat sat sequence, and you notice that the metaphysis has some red marrow, which is similar or slightly brighter than the adjacent muscle, but on the T2 it becomes brighter because it's more vascular. The same goes for the glenoid. There are some exceptions to the rule that we should not have red marrow in the epiphysis, and you can see particularly in the proximal humerus and the proximal femur some focal areas of red marrow that are parallel to the subchondral bone, and you can see here in this example just a small amount of red marrow, which is normal and should not be considered abnormal. In the hips, we often see this linear pattern in the hips that should not be mistaken for fractures. They result from the combination of red marrow and persistent trabeculae. And this pattern of persistent trabeculae mixed with the red marrow can give you this appearance sometimes of lines in the proximal femur. And you can see how pretty symmetric it is. And it was the Eiffel Tower was designed, and the designer was Gustave Eiffel, and he was inspired by the trabeculae in the proximal femur. So here it is. The other exception to the rule is the presence of red marrow in the distal metaphysis. I said previously that in the adult pattern, only the proximal metaphysis has red marrow, but reading MRIs of the knee, we see very commonly some red marrow in the distal femur and even sometimes in the proximal tibia. And this happens more commonly in women, particularly overweight, and also in smokers and athletes, and should be considered normal, but you also need to judge the single intensity. So the single intensity here, you can see that the marrow has a slightly higher signal than the adjacent muscle, so it's normal. Here I put the same patient on your left. It's a coronal T1, and you see here this patient on the right has lymphoma, and you see that the marrow has a more nodular pattern. On the background, you see some foci of normal red marrow, but this has a lower single intensity. However, if you compare it to muscle, it's not quite dark, but if you're not convinced, the T2 sequence was convincing, because here in an adult, the red marrow should not be so much brighter than the adjacent muscle. So this patient had lymphoma. In the pelvis, the bone marrow, it is the axial skeletal, so the bone marrow persists throughout the adult life, and often in a patchy way. So sometimes people think, well, it looks abnormal, it looks too heterogeneous, but in the pelvis, it's a very common finding. And so if you see that this marrow has a patchy appearance, but the single intensity is right for red marrow, it's a normal finding. In the spine, we like to compare the marrow to the adjacent disc. So choose a normal disc, and the marrow should be slightly brighter than the adjacent disc. And this is a normal example. And here you have a patient whose marrow is abnormal. The single intensity of the marrow is slightly darker than the adjacent disc. And when the pattern is diffuse like that, sometimes it's easy to overlook. So you have to really question yourself, is it normal on T1 to have such a dark marrow signal? When evaluating the marrow, the sequences we use are very simple. We like the T1 Spinnacle sequences because you have a lot of contrast between the bright fatty marrow and any abnormal process in the marrow. We the proton density and the T2 sequences without fat saturation, you have to be very careful. You lack contrast and you can easily overlook a lesion. T2 sequences with fat saturation are good to evaluate the marrow. However, we're often faced with the problem of unequal fat saturation. So stir imaging is good because you get rid of that problem. Gradient echo imaging is not good to evaluate the marrow because the trabeculae cause too much susceptibility artifact and it obscures the finding in the marrow. So even sometimes we have an injury, a patient, we know there's bone marrow edema on the T2 weighted sequences, but it's very hard to find on the gradient echo sequences. This is an example of a patient with multiple myeloma, and you can see on the coronal proton density sequence that the marrow does not look very abnormal, but when you look at the T2 fat-sat sequences, you can see all the areas of abnormal marrow that are very bright. And this, because on the proton density sequence, you lack the contrast, and so the tumor will blend with the underlying marrow. This is another case, a patient with prostate cancer and complaining of right leg pain. And this was some of the last images from a lumbar spine MRI. And the lumbar spine MRI, there was nothing significant, but on the axial T2 sequence, you look at that and, well, the marrow does not look strikingly abnormal. It's an axial T2 non-fat sat. The other sequence that was available was a T1 sequence without fat sat. And you can see here, this is normal marrow, but look here, the fatty marrow is replaced in the sacrum and in the iliac bone. And a CT was available, and you can see that there's a large lytic lesion here involving the medial aspect of the iliac bone and in the sacrum. So be cautious when you look at T2 sequences without fat saturation. You can miss big lesions. Gadolinium enhancement for evaluation of bone marrow disease has not been proven to be very useful in clinical practice because there's a lot of variation of bone marrow enhancement depending on the age of the patient. Some studies have evaluated diffuse bone marrow disease and have determined that over the age of 30, if there's an increase in single intensity of more than 40% following IV injection of gadolinium, then it's abnormal. It has to be considered abnormal marrow, but that's not very sensitive, and it misses all the low-grade diffuse marrow infiltrations that can occur. So now I will discuss some of the bone marrow disorders that we encounter. So we can have in the marrow an increase in the red marrow, either because there's a failure of conversion or because there's reconversion because of an increased demand, for example, so the patient reconverts from fatty marrow to red marrow. We have diseases that decrease the red marrow, so we have myelodepletion. And then we have disorders with infiltration of the marrow, either by benign or malignant cells. We can have marrow with ischemia and edema, and I'll show some examples of these. So reconversion from yellow to red marrow occurs commonly in long-standing chronic anemias. Also in patients with congenital heart disease, patients who are taking drug therapies such as hematopoietic growth factor that is given during chemotherapy to decrease the time the patient has myeloid depletion. Patient who has endurance activities, such as patients who train for marathons, often have a marrow that looks more, have an increase in the red marrow. Patients living at high altitude also can show an increase in their red marrow. Pregnant patients are also a category. And then when the reconversion occurs, it occurs in the reverse form from proximal to distal. So we recruit first in the axial skeleton, then the proximal metaphysis, and then the diaphysis, and finally the epiphysis. So in chronic anemias, patients with chronic anemias have an increase in the marrow iron stores, and that is because of ineffective hematopoiesis. So this increase in iron causes an alteration in the signal intensity of the marrow. Also, these patients often get a lot of blood transfusions, and that can also alter the signal intensity of the marrow. So that increase in iron store causes a low marrow signal on T1 and a bright T2 signal. So these patients have more red marrow because they're trying hard to reconvert, and the marrow that, has also more iron in it. So all this contributes to having a low marrow signal on T1. Thalassemia is a congenital disorder that has a variable expression, whether the patient is homozygous or heterozygous, so you can have a variable appearance of the disease on MRI. The erythropoiesis is ineffective, so the patients have expansion of the red marrow. They present with massive splenomegaly, and this splenomegaly causes splenic sequestration, and therefore increasing the anemia. And they also have iron overloads in the heart, the liver, the pancreas, and the skin. So this is a patient with thalassemia minor. So you notice that the marrow signal is pretty consistent with red marrow, but the distribution is abnormal. You have marrow in the distal metaphysis, but also in the epiphysis, which should not be seen in an adult. And here on the T2 weighted sequence, you can see that the marrow signal follows that of the muscle. So the signal is right, but the distribution is abnormal. This is another patient who had, because of the increased demand for hematopoiesis, had paraspinal masses, which turned out to be extramedullary hematopoiesis. They can also have expansion of marrow cavities, such as seen in the skull, because of an increased demand. Sickle cell disease is also not infrequently encountered. 0.15% of African American children in the US are homozygous, and that abnormal hemoglobin causes the erythrocyte to become rigid and causes vascular occlusions and bone infarcts, and that can cause hemolytic anemia. They are also at risk for osteomyelitis, which we have to keep in mind when we evaluate these patients. And so on imaging, we will see an abnormal marrow, bone infarcts, and the H vertebra, which actually corresponds to infarcts of the vertebral body, which causes that abnormal shape. So this is a patient with sickle cell disease, and you can see on this coronal T1 the marrow that appears very dark, and that's due to a combination of hematopoietic red marrow and bone infarcts. And you can see on the T2 weighted sequences the multiple bone infarcts. The bone infarcts, we also commonly see them elsewhere in the long bones. So here in this example, the very characteristic appearance. In the hips, the avascular necrosis tends to be anterolateral. We look for the double line sign, which is that rim of bright T2 signal seen in 60% of patients. And when we have large bone infarcts, especially if they involve the articular surface of the bone, they can lead to a collapse of the subchondral bone. This is a 18-year-old student who came to us from the East Coast after a flight. She complained of bone pain and had this imaging of her lower leg, and you can see that she had some abnormal marrow in the tibia, and on the T2 sequence it became very bright. And notice here on the axial images she also had some periosteal reaction. So this was diagnosed as an acute bone infarct. So you don't have that classic serpiginous low single intensity line. You have more a diffuse pattern of edema, which in the right clinical setting is consistent with an acute bone infarct. Now it's difficult to distinguish that from acute osteomyelitis, which because she had sickle cell disease is in the differential. She had a very low-grade fever, which can be seen in acute bone infarcts, but did not have an increase in her white blood cell count. So she was treated conservatively, and turns out to be it was not osteomyelitis. She developed the more chronic classic form of bone infarct with those serpiginous lines. Drug therapy, as I mentioned before, can also influence the appearance of marrow. So this patient has chronic sideroblastic anemia, which alters the appearance of the marrow, but she's also taking hematopoietic growth factors. So both of that can cause here abnormal marrow in distribution. So she has red marrow in the epiphysis, but also the signal is wrong, is abnormal, because the signal intensity is lower than the adjacent muscle on the T1 sequence. Myeloid depletion can occur following radiotherapy or chemotherapy. We can see that also in anorexic patients. It can also be found in aplastic anemias, whether it's idiopathic or following viral infections or secondary to drugs. The marrow in aplastic anemia has a very variable appearance. It can be normal, it can be completely fatty, it can be heterogeneous. So the appearance is not specific. This is a patient who had radiation therapy, and you can see that these three vertebral bodies in the mid-thoracic spine are much brighter than the levels above and below, and so this is secondary to radiation therapy. Initially, following radiation therapy, we can have edema in the bone, which can be confusing if you're not aware that there was very recent radiation therapy. But then, in the subacute phase, there's a fatty replacement of the marrow. And this can be reversible, particularly in children. They have a higher capacity for regeneration. It's also dependent on the dose. So the higher the dose, the lower there is a chance for regeneration. This is also a patient who had radiation therapy, and you can see how very sharply demarcated the marrow is, very fatty here, and becomes very abnormal more distally. So this patient had radiation therapy in his left hip. So red marrow is more sensitive to radiation changes, and so children are more sensitive to radiation therapy. However, they have a higher potential for regeneration, and typically when regeneration occurs in the vertebral bodies, it's at the periphery, and you have this pattern here, a band-like pattern at the periphery of the vertebral bodies. Sometimes we see complications of radiation therapy, and we have to keep them in mind so we won't diagnose tumor recurrence, and particularly with insufficiency fractures that are very common following radiation therapy. Sometimes patients develop osteonecrosis following radiation therapy, and finally the most long-term complications such as osteochondromas, osteosarcomas, malignant fibrous sarcomas are to be kept in mind. So this patient had a history of prior radiation therapy and developed pain, and the MRI revealed this abnormal marrow pattern in the sacrum, and it was a very low T1 single, bright T2 single, and so we were concerned that he had tumor recurrence. But he had also other areas of marrow edema, and in the parasymphyseal area we could see this little line parallel to the pubic symphysis and consistent with an insufficiency fracture. And if you don't see the fracture line on MR, because sometimes there's so much edema surrounding the fracture line, it can obscure, the edema can obscure the fracture both on the T1 and the T2 sequences. CT may be valuable because it can demonstrate the break in the cortex, as in this patient, and confirm that this is an insufficiency fracture. So the location will be a good clue to whether or not it is an insufficiency fracture. This is a woman in her 50s that as a teenager she had radiation therapy for plantar warts. So I wasn't aware that this was done in the past, but apparently that was a treatment, and she developed that painful mass in her foot, and on MRI she had this mass adjacent to the calcaneus and abnormal marrow, and was a sarcoma. Post-chemotherapy, the marrow can also demonstrate changes. As in radiation therapy, in the first few weeks you can have edema in the bone and followed by some fatty marrow replacements. So in this example here you have L2 and L4, which were abnormal before treatment, and following treatment developed that fatty marrow, which is a good sign. The vertebral bodies adjacent to that developed a lower single intensity, and this was shown to be regeneration of the red marrow rather than tumor. So be aware of that possibility when you evaluate the patients with known cancer. Benign abnormal cells can also infiltrate the bone marrow, and I'll show a few examples of these. Gaucher's disease is a metabolic storage disorder caused by a deficient enzyme, causes accumulation in the marrow of glycolipids, which alter the single intensity of the marrow, so that the marrow will have a decreased T1 and an T2 single intensity. Gaucher's disease has a predilection for the distal femurs and will cause the characteristic Erlenmeyer-Flask deformity. Patients will also have a tendency to develop bone marrow infarcts and often have also a large spleen. So this is an example of a patient with Gaucher's disease. He had the deformity of the distal femur, the Erlenmeyer-Flask deformity. And notice that the marrow, although the single intensity is not very abnormal when you compare it to muscle, there is some red marrow in the epiphysis, which is abnormal, and also some red marrow in the diaphysis, which is in adults should not occur. And this is another patient who had also on this T1, you can see that there's complete infiltration of the marrow. This is a patient with sarcoidosis. I showed an example this morning, and this patient had multifocal lesions in the bone, non-specific, but keep in mind that patients with sarcoidosis, occasionally you can see this pattern in the bone. They usually end up having a biopsy to prove that it's only what we're looking at, but at least you can suggest a possibility. Paget's disease is not really a bone marrow disorder. It's more a metabolic disorder that involves the trabeculae. This is a patient who had the lytic form of Paget with the classic blade of grass appearance in the femur here. When the patient has the lytic phase or the mixed phase, we can see an alteration in the marrow signal caused by the increased osteoclastic and osteoblastic activity involving the trabeculation. So keep in mind that this can cause a confusing picture on MRI. It's very useful to have the plain film and to see that the patient has some Paget's disease underlying that, because it's not always very obvious on the MRI. The patients with Paget's disease are at risk of fracture because the bone is weaker, and Meiningen transformation in less than 1% of cases. So this is an example taken from the literature of Paget's disease, and you can see on the coronal T1 image that the marrow does not look very abnormal, but on the T2 signal there's some increased signal intensity. You can see that the trabeculation are coarse, which is characteristic of Paget's disease, but on the T2 sequence, it's very hard to come up with a diagnosis of Paget's disease. You can suggest it on the T1 here, where you see the coarse trabeculation, and the plain film will also reveal it. Myelodysplastic disorders are pre-malignant bone marrow abnormalities where you have abnormal proliferation of a cell line. They are unstable and have a tendency to develop acute leukemia. Usually diagnosed around the age of 60, and the patient complains of fatigue, weight loss, easy bruising, fever, anemia. And the different disorders are primary myelofibrosis, polycythemia vera, where you have the erythrocytes that replicate too much in the marrow, essential thrombocythemia, and chronic leukemia. So myelofibrosis can be primary or secondary. It can be secondary to cancer treatments, radiation, but it can also be primary, and the bone marrow biopsy will reveal a lot of fibrosis and decreased fat in the bone marrow. These patients, because they don't have a marrow that can produce normal red blood cells, will receive repeated blood transfusion, which will contribute to the lower signal intensity. So the fibrosis will, with the repeated transfusion, cause a low marrow signal on T1. On radiographs, you will find sclerotic bones, a low T1 and T2 marrow signal, and these patients also have splenomegaly. So this was a patient who had dense bone. It was around 60, 65 years old patient, dense bone here. And on the T1, you can see that the marrow signal is very dark, darker than the adjacent disc. And on the scalp, we had this enlarged spleen. So the diagnosis was pretty characteristic for myelofibrosis. This is a patient with polycythemia vera, where you can see that very homogeneous low marrow signal on T1. Okay, so there's absolutely no fatty marrow, and on the T2 becomes much brighter than adjacent muscle, but very homogeneous. Chronic leukemia. Patients have a more indolent course with prolonged survival, but they don't respond well to chemotherapy. The bone marrow is usually hypercellular, and the abnormalities are usually found in the axial skeleton, the pelvis, and the proximal femurs. So this was a patient, 55-year-old, who presented with fatigue and anemia. And on MRI, you can see that he has some marrow that is not fatty in the diaphysis, so that is abnormal. on the stir sequence, it's very hard to detect that there's any abnormality. There was a study done to evaluate how efficient MRI was in evaluating patients with chronic leukemia, and actually it's not very good. They failed to detect 41% of patients with chronic lymphocytic leukemias because the amount of abnormal cells in the marrow is variable. So if you have a low-grade infiltration of your marrow, the MRI may fail to detect it. This was an interesting case. A patient, a 25-year-old man who had a sarcoma in his thigh, and looking at his bone marrow, we saw, well, he does have some low signal in his diaphysis, where he should not. He hadn't been treated, he wasn't taking any drugs to stimulate the marrow, and actually he had a very elevated white blood cell count, and this is a recognized paraneoplastic manifestation of sarcomas where patients, there's an increased production of granulocyte colony stimulating factor by the tumor, causing this abnormal marrow signal. And the patient was treated, the marrow went back to a normal appearance. There was no demonstration of abnormal cancer cell in the marrow, and his white blood cell count went back to normal. Metastatic disease is commonly encountered and usually present as a low T1 signal, making it easily visible on a T1 weighted image where it stands out against the fatty marrow. The T2 signal, however, is variable. It can be low or bright. Lytic metastases tend to have a bright T2 signal. Sclerotic metastases are more variable in presentation. They can be dark on T2, sometimes intermediate, or even bright. The halo sign, I'll show you an example, is a rim of high T2 signal or rim enhancement around a lesion, and that's very specific for a malignant lesion. So this is a patient with breast cancer, and you can see on the sagittal T1 on a background of hematopoietic marrow, because she was taking some erythropoietin. She had those nodular areas of lower signal intensity, and that became brighter on the T2. So that's a very non-specific but very common appearance of metastases. This was a presentation for a 43-year-old woman who had lung cancer, and she had on CT multiple, very dense lesions that simulated bone islands, but on the MRI, on the T2 weighted sequence, you can see that there's this halo that surrounds the sclerotic lesion that we saw on CT, and that is not consistent with a bone island and indicated that she had metastatic disease. So look for that sign on the T2 sequences or following IV injection of contrast. Incidentally, she also had a pretty extensive avascular necrosis in her hip. Multiple myeloma is the most common primary neoplasm of bone, usually seen after the age of 40. And these malignant cells produce an osteoclastic stimulating factor. It can be be solitary. In this case, we called it a plasmacytoma. Can be diffuse, simulating leukemia. And it usually has a low T1 signal, but a variable T2 signal. Up to 20% of patients with known multiple myeloma can have a normal MRI despite diffuse marrow involvement at the bone marrow biopsy. So be aware of that. However, these patients tend to do better. They tend to survive longer and tend to respond better to treatment. So this is an example of a patient with multiple myeloma. You can see again that diffuse pattern of low marrow single in the spine, easily overlooked here on the sagittal T2 sequence because it's so homogeneous. He also had compression fractures. So on the T1, this marrow is too dark and is abnormal. So these were pathologic fractures. MRI is much more sensitive, of course, compared to plain films, but also to the bone scan. So MRI in multiple myeloma can also be helpful to guide a bone marrow biopsy. So if the initial biopsy was negative, we can obtain an MRI and try to guide them to where to do the biopsy. It can also be used as a measurement to how the patient responds to therapy. And as I said before, they tend to do better the more normal their MRI, that they have a longer survival and a better response to treatment. Leukemia and lymphoma are also sometimes evaluated with MRI. Leukemia tends to be more diffuse, whereas lymphoma tend to be more multifocal, although there's a lot of overlap between the two diseases. In children, because they have a greater proportion of red marrow, these MRIs are more difficult to evaluate because there's a lot of overlap between the normal red marrow and infiltration by abnormal cells. So this patient had leukemia. So on the sagittal T1 image, again, a diffuse pattern of bone marrow abnormality, low T1, slightly lower than the disc. The marrow on the T2 does not look abnormal. We can expect on a sagittal T2 fat sat that the vertebral bodies will be dark. And post-gadolinium, because the involvement was so diffuse and homogeneous, we cannot even detect it with the gadolinium. So really it's the T1 that tells you that there is something going wrong. Now bone marrow edema can also be seen. I'll show different diseases. Some of them Dr. Resnick shown on his previous lecture. So transient bone marrow edema, previously also known as transient osteoporosis of the hip, was initially described in the third trimester of pregnancy, now typically seen in middle-aged men. And now is it early vascular necrosis, a fracture? Patients on MRI have this very intense bone marrow edema involving the femoral head, the neck, and the intertrochanteric area, which is sharply demarcated. And now with the better MRIs, the higher resolution, you can see most of the time you can see a little subchondral line. So actually that transient bone marrow edema are probably subchondral insufficiency fractures. It's, like I said, more common in men in comparison with women. That is not known why. It causes pain and usually resolves within 6 to 8 months. Well, this pattern of edema does not cause any diagnostic problem. You've seen this ACL tear with the characteristic pattern of bone contusion and osteochondral impaction here. And this other patient, you can see he had a valgus type of injury with a tear of his tibial collateral ligament and contusions on the contralateral side. So that doesn't cause any diagnostic problem. This patient had a history of prostate cancer and had hip pain, and on the plain film had a sclerotic lesion, so they were concerned he had a metastasis. And on the MR, he did indeed have some bone marrow edema, but you can see amongst that bone marrow edema this line. So actually it was an incomplete fracture surrounded by a lot of edema and new bone formation, which mimicked sclerotic mets on the plain film. Insufficiency fractures commonly occur in the pelvis and have very specific target sites. These are the most common in the sacrum, paralleling the sacroiliac joint, sometimes going in a transverse pattern through the sacrum. Parasymphysial are very common also, and if you see one, you should look for another because there are often multiple. And here in the pubic rami, superior and inferior is also. Another one that we see less often is at the acetabular roof. So you have this sometimes irregular line at the acetabular roof. That's another site for insufficiency fractures, and also in the iliac bone. So this patient here had these fractures that are very typical. This was a T1 fat sat post-gadolinium. I don't remember the reason for obtaining the gadolinium, but it showed very nicely the lines of the fractures here, and he also had a parasymphysial fracture. So when you see that, look elsewhere at those target sites, because more likely than not you will find another insufficiency fracture. In the knee, Dr. Resnick talked about sunk, which we now, we called previously spontaneous osteonecrosis of the knee, which we now think are more likely to be insufficiency fractures, most commonly seen in postmenopausal women who develop an acute onset of knee pain without any history of trauma. And it's often associated with meniscal root tears. And on MRI, it will have that very characteristic appearance of a thickening here of the subchondral bone plate, that linear pattern surrounded by a large amount of edema, more edema than would be expected, let's say, if the patient had osteoarthritis. So this is a pattern that we commonly see in middle-aged women, and look for the meniscal root tear at the posterior horn of the medial meniscus. They often have that in association. This is another example of an insufficiency fracture. Here he had intense bone marrow edema in the talar head and neck. And look here, there's this subtle thickening here of the subchondral bone plate. So this is another site that we occasionally see insufficiency fractures. Bone marrow edema can also be in reaction to adjacent soft tissue abnormalities in patients who have bursitis, tenosynovitis, like we see sometimes in patients with severe tenosynovitis of the tibialis posterior tendon in the ankle, and you have adjacent bone marrow edema in the medial malleolus. If there's an infection in the surrounding soft tissues, you can have reactive edema in the bone, and also calcifying tendinopathy. So this is an example of a patient, a 47-year-old man who played golf intensely while attending a medical conference. So obviously this won't happen to you since you're all here, but he had this severe pain and had this calcifying tendinopathy in his rotator cuff. And on MRI, he had this intense bone marrow edema. Now, as often it happens, the MRI was obtained before the plain film, so we have this pattern of edema, not a clear fracture, and he didn't have any history, you know, playing golf and developing a fracture. It seemed a bit stretched, so finally we saw this little low signal here in the bone marrow, and that is actually calcification that has eroded into the bone and causes this severe inflammatory reaction in the bone. But if you have the plain film, it's much easier to diagnose this, because this can be puzzling and even mimic a tumor. So in conclusion, be aware of the normal pattern of bone marrow, the normal appearance, and its normal variations. Remember to look at your T1 sequences without fat saturation and your stir sequences. They're the most useful sequences. Diffuse marrow involvement is tricky, can be easily overlooked. And benign and malignant diseases can often look very similar, so a good clinical history will be most useful.
My plan here is to kind of provide you with some information that will make you better at interpreting knee injuries, particularly in the acute or subacute stage. I entitle it Detective Work for the Radiologist. The reason I do will become obvious a little later in this talk, but I want to start at the very beginning and make you aware of the major motions and axes of movement that exist within the human knee. The most prominent motion that we deal with in the knee takes place along this horizontal axis shown in orange, and this, of course, is the motion of flexion and extension of the knee. The second axis of movement, obviously less dramatic in the normal knee, would be entitled varus or valgus. Some people would call this adduction or abduction, and it's along a green axis here, which runs in an antero-posterior direction. The third axis, also not with dramatic motion in the knee, but certainly some motion, is the vertical axis shown in blue, that runs from the top to the bottom through the knee, and this would be, of course, external and internal rotation. If we add to this the ability of the femur and tibia to move with respect to each other in a translational effect, then we end up with three further movements along each of these three primary axes. I'm showing with the pink arrows here just antero-posterior translation, but similar translation does occur in a medial-lateral and supero-inferior direction. So if you go to an anatomy book or a knee text, you will see that there are 6 degrees of freedom with regard to the movement that takes place at the knee, and this explains those 6 degrees of freedom. In the middle of the tibia is a large bone block that you all recognize on radiographs, and this is called the intercondylar eminence of the tibia. As you know, in most of us, there are 2 tubercles within the intercondylar eminence, a medial and lateral. In some of us, there's a third anterior one that's called Parsons knob. This bone block serves to restrict certain movements, including varus and valgus movement, and certain rotational movements that might otherwise take place in the knee. Attaching to this central bone block are the 2 collateral ligaments, the anterior and posterior cruciate ligament. I think that you should regard these as central collateral ligaments of the knee when you try to understand the biomechanics of the knee, and I will explain this in a little more detail later on. Surrounding these central ligaments, we have a peripheral envelope of many, many supporting structures. These include tendons, these include ligaments, and they are most concentrated in 2 particular regions: the posteromedial aspect of the knee, and I show that with all these structures here, and the posterolateral portion of the knee. Minnie will be talking in great detail about injuries of the collateral ligaments, the peripheral collateral ligaments, and spend time on both the posterolateral and posteromedial corners. Our analysis is made difficult not only because of the great number of structures, but many are obliquely oriented and many are close together and very fine structures, which makes it difficult sometimes to assess them directly. Therefore, there are some secondary findings, as she will talk about, that allow us to determine whether or not some of these finer ligaments and supporting structures are normal or abnormal. Finally, as I will talk about this afternoon, we have the menisci, the medial meniscus and the lateral meniscus, and although these are not primary stabilizers of the knee, they become secondary stabilizers, particularly when something else is wrong with the primary stabilizers of the knee. And we will talk about the patterns of failure of the menisci later today. As with tendons and many other structures, there are well-recognized building blocks that create ligaments. And this is kind of a representation of the names that are used to describe the building blocks, starting with the very smallest, the tropocollagen, getting into larger and larger groups of collagen fibers, ending up with bundles of collagen here in gray, present within the entire ligament. As you probably recognize, I'm a real fan of collagen. I think it explains a lot of the biomechanics of the musculoskeletal system, and we will be talking about collagen in this talk and also in the meniscal talk that I will cover later today. So if we look at the general appearance of the collagen bundles in a ligament, the ligament in red, the collagen bundles in gray, the major collagen bundles within a ligament exist along the lines of tension, and hence they are oriented along the long axis of the ligament, ideally suited to resist tensile force applied to that ligament. Now, there are individual variations when we look at one ligament compared to another. For example, with the cruciate ligaments, there's a helicoid arrangement of collagen around the periphery, which give the anterior cruciate ligament in particular some interesting characteristics. But this is the general architecture, and it'll be the same when we talk about tendons tomorrow, longitudinal collagen bundles. There are certain ligaments in the human body that are at risk for injury. There are 5 characteristics of those vulnerable ligaments. I show them on this slide, but for the knee, I'm only going to emphasize briefly the first of these. And that is certain ligaments, such as the anterior cruciate ligament, pass through constricted areas, such as the femoral notch, making that ligament vulnerable to injury in certain positions of the knee. In particular, with regard to the anterior cruciate ligament and also to the posterior cruciate ligament, the position of hyperextension is a bad one. We'll talk about hyperextensive injuries, but you can see how the ligament, the anterior cruciate ligament, may be made vulnerable because it is jeopardized by the sharp intercondylar roof. Here I show you an incomplete tear of the anterior cruciate ligament on your right. There are 3 patterns of failure that occur within the substance of a ligament. The first of these is a complete or full thickness tear, illustrated here, which typically is related to transverse or obliquely oriented defects through the ligament that will interrupt every single collagen bundle in that ligament. So on physical testing of the ligament, it will obviously not be normal. I could show you many different examples. I show you one of a complete tear involving the mid portion of the anterior cruciate ligament. Certain ligaments, such as the anterior cruciate ligament, with that helicoid arrangement of collagen, react to a tear through spasm. And therefore you get this recoil of the ligament, and we see that particularly with regard to the anterior cruciate ligament in the form of this anterior displacement of the torn fibers. We call that stump entrapment. It can limit full extension of the knee following an anterior cruciate ligament tear. The second pattern of failure within the substance of a ligament could be called a partial non-delaminated tear. We don't use this terminology on the report, but you can see what I mean by it. It's a transversely or obliquely oriented defect that will interrupt some of the collagen bundles, but not all of them. The orthopedic surgeon comes around and will inspect this knee and do various stress testing, and depending on how many of the collagen bundles are interrupted, that knee will be judged stable or unstable. The example I show you is that of a posterior cruciate ligament tear that is not complete, but near complete, and is extending across as a transversely oriented defect. The third pattern of failure that may occur within a ligament occurs along the long axis of the collagen. Much as we spoke about yesterday, this would best be judged a delaminated tear. These can be complete or incomplete, that is, they can go from top to bottom or side to side or only part of that distance. Depending upon the extent of this delaminated tear and how many collagen bundles are interrupted, this tear may in fact look stable at the time of physical examination. Now, these tears occur both acutely and with repetitive stress. So you might see this delamination not as a single event, but following multiple events. And in fact, that is the pattern that we see, particularly with regard to the anterior cruciate ligament. We tend to call this different things. I don't know, you might call it cystic degeneration. We use that term if this occurs in an older person, but we also see this in young people. We might call it cystic transformation. And I think basically the failure or defects that exist between the collagen bundles. Because of the disorganization of collagen that comes with advancing age, and we could call that ligamentosis, this pattern of failure increases in frequency as we get older. I'm sure you've seen cases like this of this cystic transformation of the ligament. There are three patterns of failure that occur where a ligament attaches to bone. The first of these I made reference to earlier in this course when I told you that thick ligaments or layered ligaments may fail through their deep fibers, which will detach from the bony margin. We see this about the elbow, and that is an example, like the one I showed you yesterday, of an anterior bundle of the medial collateral ligament peeled away from the sublime tubercle. We see this with regard to the medial patellofemoral ligament, and many will be talking about that, as well as the anterior bundle of the inferior glenohumeral ligament, which I will be talking about later in this course. So this is a peeled back lesion at the attachment site. The second pattern of failure that occurs is a partial or complete detachment through the ligament at its site of attachment. This is an important injury to note. Here I show it with a posterior cruciate ligament failure right at its femoral attachment. Because at least theoretically these are easier to repair. You reattach the structure. Big difference than an intraligamentous pattern of failure. So you have to describe this on your report. These are uncommon, both with the posterior cruciate ligament and with the anterior cruciate ligament. Intraligamentous failure is more common. And then the final pattern of failure is where the ligament pulls off a piece of bone, and of course I could show you a whole variety of these. I show you the classic example where the ACL has pulled off a portion of the intercondylar eminence of the tibia. We see this more often in children than in adults, but certainly in both age groups you may have come across this lesion. Now, when you look for edema at a site of an avulsion injury, I mentioned yesterday that it depends somewhat on the pattern of attachment of that ligament to bone. In general, tensile injuries don't produce a lot of marrow edema. The avulsion fractures are the ones we miss. But in certain areas of the body, there is a direct insertion where the ligament fibers penetrate the cortex at right angles. And in those cases, as shown here, where we're looking at the femoral insertion of the deep medial meniscofemoral ligament, you may get a pattern of marrow edema to help you. Elsewhere, there are indirect insertions of ligaments where they penetrate the cortex at oblique angles. And in these cases, and I show you here a tibial collateral ligament avulsive injury inferiorly, there will be very little marrow edema to help you out. So I think that explains some variability in the marrow edema when dealing with avulsive or tensile injury. If we return to the subject of avulsion fractures, we can identify in the knee ligaments and tendons that may produce these avulsion fractures. And we could divide them in one way by location, as I do here, medial, lateral, central, and anterior. Now, many will be talking about some of these specific injuries. I will pick but one to at least make a comment about, and that relates to the Sagan fracture. This is an important avulsion fracture that generally indicates a tear of the anterior cruciate ligament and a high likelihood of injuries to other lateral supporting structures as well. What causes this is debated. I know everybody's been taught it's the lateral capsular ligament, but that's pretty flimsy. And if you look at your images as this one, you will always see, or almost always see, a portion of the iliotibial tract attaching to the bone fragment. So I think that is one possible etiologic factor. You know, that tract does attach to Gerdy's tubercle, but that's not the only site of attachment. It extends along the tibial rim. In any case, it's an important finding. There isn't much marrow edema with it, so you might miss this unless you had a plain film to help you. Now, this is a busy slide, okay? I realize that's the bad news. And also the bad news is that it's the most important slide. So let's kind of work our way through this. In that left-hand column, I am listing 7 possible motions that might be applied to the knee. In the central column, I am listing that structure or structures that is the primary restraint or resistance to that particular movement. In the last column on your right, I am showing you some of the secondary restraints to that particular motion. This is critical information to the orthopedic surgeon and I think to the radiologist, because what it tells you, if you can predict the motion based upon clues on the MR image, then you know that the first structure to fail will be the primary restraint, and then if it is a severe abnormal motion, one or more of the secondary restraints will fail. So all of a sudden we have a predictive sequence of events that takes place when you can figure out what that motion is. And as we go through this talk, I'm going to provide the information that will allow you to better figure out what that motion is. To show you how that might work, let's take one horizontal row of that table. The motion is valgus, the primary restraint is the medial supporting structures, and then the secondary restraints are the central collateral ligaments, the cruciate. This is an example of what happens with a valgus injury. In terms of in the normal situation where you have weight both through the medial and lateral side, when you have a valgus injury, the contact point is shifted to the lateral aspect of the knee. So at this site, you will get compressive injury. What fails in compression? The meniscus, we'll talk about that, the articular cartilage, the subchondral bone plate, and also the subjacent bone. Ligaments and tendons may fail in compression, but it is not common. Everything to the left of that contact point is under increased tensile force. You can see the moment arm of the medial supporting structures is far greater to the point of contact than the moment arm of the central collateral ligaments. And hence the primary restraint to this motion is the medial supporting structures. The secondary restraints are the cruciate ligaments of the knee. And here's the typical example showing you compressive injury with a fracture line in the subchondral bone, most likely an osteochondral fracture. And you can see here that there is a little bit of edema, tensile injury to the medial supporting structures, and even a little bit of tensile marrow edema at the attachment of the deep medial meniscotibial or coronary ligament of the knee. So that's how you kind of put this together with all of these movements. Now, there are 2 possible forces that may occur during an injury to any joint. We're talking the knee. Both may be operational or only one will be operational. The first of these forces is the external or environmental force. This is something outside of the body striking the knee. It may strike the entire region, it might strike above the joint, below the joint, what have you. It could be the helmet of an opposing football player. It could be a car or a bus or a train. It could be virtually anything striking the knee. The typical sphere of influence that you get with an external force is on the surface of the bone. You don't get it at the end of the bone. So that's why I mentioned that yesterday. Marrow edema at the end of a bone typically means something coming through the cartilage. So here you're going to deal acutely or hyperacutely with soft tissue problems and marrow edema on that side of the bone that indicates where the force struck. That makes sense. That's going to be important as we analyze MR images. That will tell us where the force came in. It could be the femur, the tibia, or both bones. To give you an idea of what it looks like, here's an example. The red arrow is showing you the force, external force applied to the knee. You'll note that this marrow edema is on the surface of the bone, in this case associated with soft tissue edema, all right, and it does not go down to the end of the bone. Now I can tell you sometimes it will, but the major edema will be away from the end of the bone. That will help you. Here in the transverse image, we can see exactly what happened. So this is what an external force looks like. The second force that may be operational is the internal force, where one bone strikes its neighbor. In the knee, in the vast majority of cases, it is the femur and tibia that collide. Now, there are exceptions, a lateral patellar dislocation where the patella and femur collide, and maybe some bizarre fibular dislocation that strikes the femur or something. But in general, for most injuries, we're talking about the collision of the femur and tibia during the injury. Here, the sphere of influence is at the end of the bone. So now we're going to deal with chondral abnormalities, problems with the subchondral bone plate, changes in the subjacent bone, all the things I talked about yesterday with regard to chondral injury and osteochondral injury. When the two bones collide, there are 4 possible pretty acute events that take place in the joint. 3 of these have fairly specific features: hemarthrosis, lipohemarthrosis, and the worst, a pneumolipohemarthrosis. We see that particularly in the hip with fractured dislocations and gas present as well within the joint. Just to give you an idea, the hemarthrosis with the 2 layers and 1 fluid level, serum and hematocrit. The lipohemarthrosis we spoke about yesterday with those 3 layers, 2 fluid levels, fat, serum, and hematocrit. And the point I made yesterday, the bubbles of fat that may be released into the effusion, shown here at the top of the effusion. When the 2 bones collide, there's going to be a reaction in the subchondral bone, and we often call this a bone contusion or a bone bruise. And I showed you a very similar case yesterday to indicate the complex appearance of these bone contusions. Okay, there's hemorrhage, there's edema, I think there are changes in fat as well, with lysis of fat producing this speckled appearance that we see on our MR images. Now, when you see these bone contusions, particularly those that extend to the end of the bone, as you would expect, with an internal force, you must closely look at the subchondral bone plate. Because if you see irregularity or depression of that subchondral bone plate, you're dealing with more than a bone contusion. You're dealing with a fracture, an osteochondral fracture. Many will show you examples, I believe, of the deep notch that occurs in the lateral femoral condyle when you have certain patterns of injury to the anterior cruciate ligament. But the other area that frequently becomes edematous is the posterior aspect of the lateral tibial plateau. And normally you don't have this shape like a 3. That is depression of the subchondral bone plate. This is not a simple bone contusion. This is an osteochondral fracture. Now, it's way at the periphery, so maybe it isn't really that important to know it's a fracture as opposed to a bone contusion, but it is an osteochondral fracture. Okay, that's the background. Now it's time to go sleuthing. We are going to become detectives, and we're going to be looking at some of these MR images and trying to figure out what is going on. Just for the historical aspect, the word sleuth was introduced many years ago from the longer word sleuth hound, which refers to a dog such as a bloodhound, which is used for tracking or pursuing. The synonyms are detective, spy. I don't like snoop because we're not doing snooping. We are going to be doing sleuthing here in the next 20 minutes or so. So in order to do this in PowerPoint, and all these slides are created in PowerPoint, it's the only thing that I know how to do on a computer. So there are only so many shapes you can use. You've seen them over and over again. So here are the shapes I'm going to use. You're looking at a frontal radiograph of the knee. I'm showing you one femoral condyle, the other femoral condyle. It doesn't matter what is medial or lateral here. And I'm showing you the tibia and another characteristic shape you can use with PowerPoint. Okay, so you're all oriented because we're going to keep this up for a while. Okay, so let's look at the external force. We already talked about it. Here I show you external force striking a femoral condyle above the level of the joint. Here we expect acutely or hyperacutely soft tissue alterations. They'll go away. You'll be left with the marrow edema, which classically is on one side of the bone, on the area of input force, and usually is not most dramatic at the end of the bone. It may not even extend to the end of the bone. Here's an example where we had a good history of a force that was applied above the level of the joint to the lateral femoral condyle. You'll note that although the marrow goes down, edema goes down to the subchondral bone, it's more dramatic away from it. That tells me this is likely an external force. This has led to tensile injury on the medial aspect, failure of the medial supporting structures, and again, I'll leave that to Minnie to cover the details of that. Ligament failure following an external force, therefore, is usually on the opposite side of the force. And there are three classic mechanisms that produce it. Valgus, which is common in the human body, a force on the lateral side, leading to failure of medial ligaments. A second, which is varus, with a force on the medial side, leading to failure of lateral ligaments. And then hyperextension, which generally has a force applied anteriorly with failure of one or both cruciate ligaments. So those are the three patterns. The second force was the internal force, so let's look at that. Force derived from the contact of one bone with its neighbor. This is more complicated, and to understand it fully, we have to take 5 different scenarios. And I've listed them there, and we're going to go through them one by one. The first of these is distraction impaction, and if you want to think of the example of this, it would be the valgus injury again. What happens is a collision on one side and distraction on the other side. And we've already talked a bit about this. You're going to see the compressive force usually on the lateral side, the tensile injury on the medial aspect of the knee. So I'll let you look at this example. And the ones I chose were chosen because we had very good histories. They're not always the best images. I'm indicating with these arrows exactly what happened, but I'm going to show you as we look at this what happened during the injury. This is what happened. This patient was struck above the level of the knee joint, throwing that knee into a valgus alignment. The external force didn't do too much other than produce the soft tissue edema here. The internal force has done a lot of damage with contusions and even depression of the subchondral bone plate. You'll see the tensile injury on the medial side with failure of the medial supporting structures. This is distraction and impaction. You see these are kissing patterns of edema. All right, that's what you look for. Are they always on both sides? No. If they're going to be on one side, it's more often the tibia than the femur, but many times you can find the edema on both sides. The second of our 5 scenarios is rotation. I'm going to rotate the tibia with respect to the femur. It could be the opposite. Now what happens is the injury, the 2 bones strike each other, kissing marrow edema in the rotated position. But when we image this particular patient, they're no longer in the rotated position. The knee has straightened out. So the general rule that we use for rotational injury are patterns of edema that are not adjacent to each other. Here's one example, and this was during a tear of the anterior cruciate ligament and an extensive tearing of the lateral meniscus. We won't talk much about that. But note the offset of the marrow edema, far more anterior in the lateral femoral condyle than in the lateral tibial plateau. This is a common pattern of marrow abnormality we see with anterior cruciate ligament tears, and in many cases, as in this case, it relates to internal rotation of the tibia with respect to the femur. And one point about that, it doesn't matter if the femur rotated or the tibia. You always refer to the way the tibia moves with respect to the femur. This is called anterolateral rotary instability. This is the mechanism that leads to a Sagan fracture and lateral ligament injury as well. So this is the classic Owry pattern that we see. The third of our scenarios is flexion. I'm going to flex the femur with respect to the tibia. It could be the opposite, but we'll do it this way. Now the injury takes place. One bone strikes its neighbor. This is kissing marrow edema at the time of injury, but of course we image not in the flex position. So when you look at these, this is what it might look like at the time of injury, but when we image, it more often looks like this. Here's the classic example. This is a skier who tore his ACL while skiing with the knee flex. Note the offset of the edema in the posterior aspect of the lateral femoral condyle and that in the posterior aspect of the lateral tibial plateau. They have swung away from each other because the knee is no longer in the flexed position. That is how you can kind of put this together and figure out the force. Injury of non-contiguous portions of femur and tibia generally indicate rotation, flexion, combinations of that, and when you see that, more often than not, there are multiple ligamentous injuries and even meniscal problems that take place. This leads to two classic mechanisms of injury that your orthopedic surgeons may know about and in fact use this terminology. Flexion varus and internal rotation, known as Owry, anterolateral rotary instability, where you get injuries of the ACL and the lateral ligaments, the Sagan fracture. Flexion valgus and external rotation, known as AMRY, anteromedial rotary instability, where you get injuries to the ACL and the medial ligaments. The example, the prototype, is an O'Donoghue's triad. That is an AMRY mechanism of injury to the knee. So those are the two mechanisms with this particular pattern. We go to our fourth scenario of our five, and that is hyperextension. In order to understand what happens with hyperextension, we have to change from a frontal radiograph to a lateral radiograph. Easy to do in PowerPoint. You're now looking at a lateral radiograph of the knee, femur and its condyles above, tibia below. The typical, although not invariable, scenario with a hyperextension injury is a force applied to the anterior aspect of the knee. That's the external force. You may see it as soft tissue edema or marrow edema on the surface of the bone. This will throw the knee into hyperextension. As it does so, the femur and tibia may collide, so the marrow edema from the internal force is on the anterior aspect of the femoral condyles and tibial plateaus. If you see marrow edema or fractures involving the anterior aspect of the medial femoral condyle or the anterior aspect of the medial tibial plateau, your first thought should be hyperextension. Your second thought should be beware cruciate ligaments, and your third thought should be beware the posterolateral corner of the knee, because that's the classic thing that will happen with this sort of injury. So let me show you the example. It's not a pretty image, but we had a great history here. This was a patient who was struck above the level of the knee like that, and there was only some subtle edema right here in this stir image that showed the impact of the external force. The rest you can tell what happened. The knee was thrown into hyperextension with collision of the anterior surfaces of the femur and tibia, and the internal force was at work. If I can figure that out, I know now the stabilizers, primary and secondary, I'm going to look for injuries to those stabilizers. Typically the cruciate ligaments and also the posterolateral corner of the knee, an important site of injury with this mechanism. The final mechanism is pure translation. Now, it's hard to work this out because a lot of times with translation there is also flexion and sometimes rotation. But let's take the rotational component away from this, and we're talking pure translation, and statistically that is anterior translation of the tibia. And during the injury, usually what happens, the knee flexes. What typically is seen with a pure translational injury of sufficient magnitude, marrow edema both on the medial and lateral aspects of the knee, both with an offset. Okay, in that the tibial edema is more posterior than the edema in the mid portion of the condyle. And here's an example of what it might look like. Now, this is not pathognomonic of anterior translation. There are other theories that will tell you this is rotational, all right, and then there is a contra-coup mechanism at work. But in some cases, it is not a contra-coup mechanism. Look at the marrow edema on both sides. I'm showing you lateral and medial, and you'll see an offset on both sides. Typically, with these, because of the shape of the tibial condyles and the way the tibia translates differently on the medial and lateral side, the lateral edema is further apart than the medial edema. Note that on the medial side, the areas of edema are closer together. This is very, very characteristic. And in general, the lateral edema is more profound than the edema occurring on the medial side. So this is translation. You put it all together, and you end up with a chart that looks like this. This is not the whole story, but let me tell you what this chart says. We'll start with the anterior cruciate ligament. You know, I'm a great fan of the San Diego Chargers, and I've been following them for years and years, disappointed every single year. But I like the team, all right? And in fact, I was watching how they did in the draft the last 2 days. Not so good. But in any case, they had a very good runner, okay? They don't have quite as good runner right now. But if you look at an American football runner, he's got to be fast, he's got to be shifty, but beyond everything else, he's got to have good vision. Okay, that's what. So just think of a good runner running down the field in the NFL, and he's fast and he's shifty and he has good vision. And out of the corner of his eye, he sees the other team's cornerback coming toward him. He's gotten through the line, so he's in the backfield. And the cornerback is coming toward him, and he's shifty with good vision. So what he does, he cuts away from that cornerback, avoids the external force, but twists his knee in such a way that it pops ACL. And the femur contact the tibia, what you'll see will be internal force without external force in that sort of situation. The second line, the posterior cruciate, the classic example being the passenger in the car. The car stops, the passenger doesn't. The knee strikes the dashboard. That's the external force. It drives the tibia back. There may not be an internal force. What you're going to see is the external force. With the medial and lateral ligaments, there's a lot of variability in the mechanisms of injury. Some will have external, some internal, some both. So that's the whole story, save one mechanism, and that is pure distraction, which is not common, but that means things are being pulled apart until they break. So what about pure distraction? Well, I like this mechanism because I had not a close friend, but a friend who was involved with this mechanism. He was a 42-year-old male rheumatologist, and he took up skiing at the age of 42. That was a mistake, all right? He was very cautious. He put in all the safety precautions that he could think about, all right? On the first day, first run down the mountain, first 100 feet, he ran into some trouble. When I spoke to him about this, he's one of our affiliated hospitals, he said he could not believe how fast you're going after 100 feet. That's what amazed him about the sport of skiing. So what happened? Well, here he was at the top of the mountain. Apparently he had picked a slope that was a little too advanced for him. And if you talk to the observers, they say he was coming down, it was a sunny day. He hit this snow, he did something like this. He had a soft landing, okay, and no external force. When I told him what the observers said, he said, well, that didn't do it justice. The day was sunny, but when he actually hit this, he did something like this, and he ended up upside down, covered with snow. But what he remembers most of all is during all this flipping, he remembers that his knee was being pulled apart, and he heard tearing going on in the knee. His landing was soft. He had no external force. It was all distraction. And so when we imaged him, in fact, this is what we saw: a lot of high-grade stuff on the medial side to your left, a lot of stuff in the cruciates to your right, no marrow edema because the bones had been pulled apart. So if you see a lot of ligament problems without marrow edema, you have to think of distraction. Well, we have about 15 to 20 more minutes, and I'm going to go back now and try to show you a simplified analysis, and then we'll finish up with some examples of the classic mechanisms of injury. To simplify this took me a while. I went ahead and showing you a tibia, which is the white circle, and I'm showing you it's sitting within the femur, which is this orange rectangle, and I've drawn all of these supporting structures around this joint, including the central cruciate ligaments, structures in the anterolateral and anteromedial corners, the lateral and medial supporting structures, and the posterior corners back here. When you try to summarize in a simple fashion the patterns of displacement or movement of the tibia, remember we refer to the tibia with respect to the femur, you end up with something like this. Two patterns of abnormal translation, anterior and posterior, two patterns of abnormal distraction, that is widening of one part of the joint, that's valgus and varus, and four classic translational rotational injuries, Auri-Amory, and then two that are not so common, PLRI and PMRI. So let me just show you a couple of these. When you have anterior translational injury of the tibia, and you can see it's moving forward, the white circle has shifted now anteriorly, there are four stages of injury. The first injury is to the primary restraint, which is the ACL. Then the medial and lateral supporting structures may be injured. The third stage is tensile injury to the posterior capsule, and the fourth stage is possible injury to the posterior cruciate ligament. So at least in theory, those are the four stages of an anterior translational injury. Let's look at posterior translation. The tibia moves backward. Here we deal with a two-stage injury. The primary restraint fails, the posterior cruciate ligament. The second area of failure are in the posterolateral and posteromedial corners. Minnie will talk about these. The posterior oblique ligament and the arcuate ligamentous complex. The third is medial distraction, or valgus injury. We've already talked about it, three stages of injury. The first are the primary restraints, which are the medial supporting structures. Then the secondary restraint, which is the anterior cruciate ligament, and then possibly tearing of the posterior cruciate ligament. Our fourth scenario is lateral distraction or varus. This is uncommon. All right, three stages. The first is injury to the lateral supporting structures as they will open up and fail. Then maybe the central collateral ligament, the posterior cruciate ligament, and tensile failure of the posterior capsule. And then the other central collateral ligament, the anterior cruciate ligament, may fail. And finally, the two classic rotational anterolateral rotary instability, where you can see internal rotation and anterior translation of the tibia, the failure to the ACL and the lateral supporting structures. And finally, the opposite Amory, where you have anterior translation and external rotation of the tibia, and the combination of ACL and medial supporting structures. So there are scenarios that will help you. If you do all of this, you end up with a list of the classic mechanisms of injury to the knee. And you can see here I'm listing 10 of them. I'm indicating that some are related to contact, external force, some to non-contact, and some to both. So what I'll do in the last 10 minutes or so is just cover some of these. Now I'm going to show you images and accurate histories to illustrate these patterns, and in fact we're only going to cover these. And I'm going to show you images from the internet that are free to everyone to use. They are not the person being imaged, but they show you pretty much the mechanism of injury. You may recognize some of those. They're classic sports injuries. I'm going to use this kind of modified Venn diagram with the ACL, the medial and lateral supporting structures, and the posterior cruciate ligament. The first injury will be a pure valgus injury. I know I've done this 4 or 5 times, but this is such a common pattern. So what happens? You're rotating along that green axis antero-posterior. So you're getting compression on the lateral side and tensile injury on the medial side. We'll put that in. So ligaments and tendons can fail through tensile injury. Compressive injury, again, meniscus, cartilage, subchondral bone plate, and subjacent bone. This is the valgus injury. It's often non-contact. I show you a couple of examples. Now, anyone who has skied can relate to those upper 2 images. Probably I've been in that position many, many times. You know the old favorite, the snowplow on your left here, right? But it can go bad, all right? Where your legs keep getting further and further apart. Now, I know some of you have had that experience. I certainly have had that. Well, that is a valgus injury, as shown by the blue arrow. And I'm sure some of you have looked down and found this situation, where the 2 skis are crossed and you tumble over that one leg, and that is a valgus injury to that knee. American football, this might explain why you would get a valgus injury. So the example I show you is a 24-year-old semi-professional American football player was struck, as shown there on the outside of his leg. That's the external force away from the end of the joint, and you'll see the tensile injury in the medial supporting structures. This is valgus. The second is a posterior translational injury. I'm sure you've seen this in your practice. Here, the tensile force is mainly in the posterior 2/3 of the joint. The compressive force is in the anterior 1/3. The typical pattern of failure is the PCL, but this can be combined, as shown in the Venn diagram, with injuries to other supporting structures. This can occur in American football if you're struck like this on the anterior aspect of the knee. Typically, the knee is slightly flexed, as it is here. The example I'll show you is that of a 23-year-old woman who suffered a high-speed head-on automobile accident during which her knee struck the dashboard and she dislocated the ipsilateral hip. You can appreciate here the injury that you would expect to the posterior cruciate ligament. These patients will, in fact, have popliteus muscle injury as well, tensile failure there. This was the external force producing damage to the patellar and patellar tendon anteriorly. So this is posterior translation. The third of our scenarios, anterior translation, a common mechanism of injury. Here we can see what happens. You have tensile injury in the anterior 2/3, compressive injury in the posterior 1/3. This explains tears of the ACL alone or tears of the ACL combined with injuries to the medial and lateral supporting structures. That's the classic mechanism with skiing. It's called the boot-induced mechanism. This is a 42-year-old recreational skier who lost his balance during a jump. The tail of the downhill ski hit the snow and pushed the back of the boot against the calf, causing the ski to run anteriorly. He heard a pop, the ACL, and he fell. And you can see beautifully this tear involving the anterior cruciate ligament, and again, the association with popliteus muscle myotendinous injury. Now this boot-induced mechanism, and I'm showing it here, relates in large part because of contraction of the quadriceps muscle. The quadriceps muscle is an antagonist to the anterior cruciate ligament. It's going to pull the tibia forward. This is resisted by that anterior cruciate ligament. But during this boot-induced mechanism with severe contraction of the quadriceps, the tibia is pulled forward, and indeed you get complete tearing of that anterior cruciate ligament. The next scenario is pure hyperextension. There is the normal situation. This is the hyperextension. You can see here tensile injury posteriorly and compression injury anteriorly. This can produce tears of the ACL, the PCL alone, or combined, less commonly, with other ligament injuries. This is the example I show you, a teenage girl who hyperextended her knee during a soccer game when she completely missed the ball on what would have been the winning goal. Here you can see the marrow edema, the classic pattern of edema we talked about earlier for a hyperextension. We'll finish up with the two rotational injuries, the classic ones. I wanted to show you what the cruciate ligaments look like in neutral in the middle, in external rotation on your left, and on internal rotation on the right. The least forgiving position for the cruciate ligaments is internal rotation because they entwine. You can see that beautifully. They actually unwind in external rotation. So even though we do get injuries of the cruciates with external rotation, theoretically, internal rotation is a more important position, making the cruciate ligaments vulnerable. There are 4 patterns of rotational injury to the knee. I've divided those into internal rotation and external rotation, anterior translation, and posterior translation. I'm only going to cover the upper part here, those associated with internal and external rotation with anterior translation of the tibia. And I wanted to illustrate with these 2 pictures from the internet what we're talking about. In American football, if in fact what you see is the foot planted and the body cutting toward the planted leg, you are getting internal rotation of the tibia. So if you tear your ACL doing this, it's going to be the Lowry mechanism. As compared to this one, where the foot is planted and the person is cutting away from the planted foot, and this, of course, is external rotation of the tibia, and this is the Lowry mechanism that we see. Now, there are other reasons you get Lowry, because you can have someone striking the leg right here at the same time, an external force, but you don't need the external force. So if we look at the first of these 2, flexion varus and internal rotation like this, you can see why the tensile injury is to the anterior cruciate ligament and to the lateral ligaments of the knee. The example I show you is this one. This is a star halfback for his high school football team. He cut around a would-be tackler, avoided him, but heard a pop, tearing his ACL, and he fell. And this is the Sagan fracture with the tearing of the anterior cruciate ligament, beautifully shown here. Note the relative lack of marrow edema. And then the final scenario, the opposite, flexion valgus and external rotation. And here you can see exactly what happens. Now you get the tensile opening up on the medial side. This explains the combined injuries of the ACL and the medial supporting structures. And to give you an example, this is a 24-year-old college quarterback who was hit from the side just above the knee as he attempted to complete a pass. You can see here exactly flexion, valgus, and external rotation are taken from the internet, showing you exactly how that would occur. Here is the external force, all of this tearing of the medial supporting structures, and note not just the medial collateral ligamentous complex, but the medial patellofemoral ligament is torn, as was the cruciate ligaments, and this would be the mechanism of Lowry. So you can, in fact, come up with a scenario. I'm not expecting you to learn this, but I think it's in your handout of all of these Venn diagrams.
So the ligaments that we're going to cover for this portion before the break are going to be the medial collateral ligament as well as its supporting structures on the medial side, and then we'll turn our attention to the lateral ligamentous complex, which includes a number of important structures, and I'll finish with the posterolateral corner. So let's start first with the medial collateral ligament. This is a structure very well seen on MR imaging, and most of us use the coronal plane for assessment of this structure. It's a band-like ligament about 1 centimeter anterior to posterior, but it has quite a long length, running from just below the physeal scar of the femur and extending several centimeters below the joint line to insert 6 to 7 centimeters below the tibial plateau, just deep to the pes anserine tendons. So we should be really assessing the entire length of this, and you'll note that on many of our MR studies, its terminal portion may not be completely included, and that's fortunate for us because injuries are generally in the more proximal portions of the medial collateral ligament. When you look at it from the side, you can see that the medial collateral ligament has a significant thickness running from anterior to posterior, and it's supported posteriorly by the posterior oblique ligament, about which I'll speak later. The superficial ligament is longer than the deep ligaments, and we'll talk about the layers here, but as you look at it from the periphery, we're really looking at the superficial medial collateral ligament, running, as I mentioned, from that level of the physeal scar down several centimeters to the medial border of the tibia. In the late 70s, Warren did a detailed anatomy analysis of the medial side of the joint and introduced this concept of 3 layers. And as you look at the medial tissues here, you can see that the medial collateral ligament is really not a monolithic structure, but that it has 2 significant layers that we can identify. And then more superficial to that is a very thin fascial layer that does not contribute to the stability of the medial side of the joint. So when we look at this, instead of just looking at it top to bottom, it's also important to look at it from outside to inside and assess both those medial and the deep components. So I'd like to supplement the analysis on the coronal plane with the axial images to really try to figure out how much of the ligament has been damaged. Michel de Messonnier expanded on that medial concept and published some articles in our radiology literature that you may be familiar with, again showing this most superficial layer which represents crural fascia and doesn't create any significant support medially, the larger superficial ligament, and then deep to that, the much smaller deep ligament which was seen in the deepest layers of the medial collateral ligament. So you can usually recognize these structures on your axial images, and a good landmark to use is where the femur turns. And that is the position where you should be able to see your tibial collateral ligament. It's usually at or just around the corner. And it's this first centimeter of tissue, this thickening that you'll see in that region. We can see these layers on our conventional coronal images as well. This superficial crural layer, which is fascial, is very thin and extends well above the knee joint. The superficial ligament is in layer 2, and then the third layer, layer 3, may or may not be seen. The deep ligamentous structures are more amorphous in their signal. They're easier to see in patients who are obese, and they're easier to see in patients who are older, who may have a little bit of fluid in the bursa that is present that intervenes between these deep and superficial layers. So you may see them conjoined together, or you may be able to see them separate, as we can see in the example on the left. The bursa is an important structure to be aware of. There is a tibial collateral bursa illustrated here on a more three-dimensional representation of the medial collateral ligament, the superficial being deep, the deep being deep, the superficial here, and in between this tibial collateral bursa. And we will see distension of this bursa under a number of circumstances. It's not always pathologic. Little bits of fluid in this bursa are often seen in patients who have osteoarthrosis and are presumably asymptomatic. Larger collections can be associated with symptoms. They're particularly common in patients who have underlying inflammatory arthropathies, but we often are not called on to image these structures. They're really diagnosed on a clinical basis and managed either conservatively or with anti-inflammatories or local steroid injection. But we should be aware of this, because seeing some fluid in the layers of the medial collateral ligament does not mean that the ligament has been torn. So as long as it's smooth, linear, it's generally more prominent at the caudal side of the space, that does not imply that the medial collateral ligament is damaged or incompetent. These are larger collections of fluid. I mentioned them when they're this size, not when they're little trace thin collections of fluid. But you can see that in this patient, there's obviously chondral problems, some very early degenerative changes, and some reactive bone edema. In the patient on the right, this was related to an inflammatory disease, slightly septated, lobular appearing bursa. And when you have the bursa, the distinction between the superficial and the deep layers becomes easier. So we can see the superficial medial collateral ligament bowed, the deep components represented by the meniscofemoral and the meniscotibial ligaments are much easier to identify. Now, injuries to the medial collateral ligament are quite common, and they are generally treated conservatively, even if they're quite high grade. So the description of these does not perhaps need to be as detailed as it does when we talk about the posterolateral corner, for example, or the anterior cruciate ligament, which are more surgical lesions. So we can see in the patients who have medial collateral ligament, there will be a number of findings. They will frequently show superficial edema. This is very nonspecific, and it's not sufficient to make the diagnosis of an MCL injury. Some of the important causes for it are if there's a Baker cyst that's extravasating, because that fluid likes to track along the medial side of the joint. Also, if there's been direct trauma, you may have a history of that. But what I find is that in many elderly patients, they tend to collect subcutaneous fluid in their prepatellar tissues, especially medially. So that can simulate the appearance. So I don't think that that alone is an adequate finding to diagnose an MCL injury. What we like to see is actual signal or caliber changes of the ligament itself. So here, as you look at the superficial band of the medial collateral ligament, you can see that there is internal signal within it that's separate from the tibial collateral bursa. It is changing in caliber. Normally the ligament is thickest at its femoral portion and then thins as we get down into its lower portions. Here we see going from thin to thick, which is abnormal. And then in more severe cases, complete discontinuities or retractions may be present. More significant injury in this patient, where the superficial ligament again shows increased signal within its substance. There are caliber changes which will often take the form of this thinning, turning to thickening. And in this case, you can see that the meniscofemoral component of the ligament has also been injured. We can see the meniscotibial component, but the meniscofemoral component is thickened. And there's often edema in these patients that can be a clue to you that you're dealing with a deep medial collateral ligamentous injury. The meniscofemoral ligament inserts about 1/3 of the way up the condyle, considerably more close to joint line than the superficial components. So that is another helpful finding. This deep component only contributes about 15 or 20% of the stability to valgus stress on the medial side. But the combination injury has the potential for more instability than if you have a superficial tear alone. So in your report, I typically include 3 structures: the superficial, the deep, and the posterior oblique ligament, about which I'll speak later, remembering that the deep and the posterior oblique each contribute about 15%, and that the bulk of stability is related to the medial collateral ligament. Those proportions vary, and they change according to knee flexion. So that's just a rough rule to consider, but the concept's important. The more of these structures that are injured, the more likely you are to have valgus instability at the knee joint. Another couple of examples. In this patient here, we can see that in addition to the meniscal pathology and valgus contusion on the lateral side of the joint, that the meniscofemoral component is abnormal. Now, when it's injured in isolation, that rarely results in any significant instability. There may be some very low-grade strain in these upper MCL fibers, but this type of injury is not treated surgically. Similar here, superficial, probably very low-grade strain. There's some signal in it, but the deep is disrupted. I have found in many cases that when there's isolated deep injury, that is associated with patellar dislocation. There seemed to be some continuity of tissue between these deep fibers and some of the layers of the retinaculum. So if you see that, just be aware that you should go and take a good look and make sure that the retinaculum hasn't been torn from a patellar subluxation. But otherwise, this is going to be treated conservatively, this kind of grade of injury. As the injuries get more severe, you'll actually see discontinuity. This is often seen in the healing phase because part of healing of ligaments involves resorption. So if the patient is more subacute, the ligaments will often look more abnormal than if you image them acutely. But we see here that the ligament has been completely resorbed and both the superficial and the medial ligaments are damaged. When you have deep ligamentous injury, also pay very close attention to the meniscus, because meniscocapsular trauma is seen in this kind of setting. So far vertical peripheral tears can be seen in the patients that have had injury to their deep medial collateral ligamentous structures. This is uncommon to see frank retraction of the medial collateral ligament. And the typical reason that it retracts and becomes balled up like this is that it's stuck on something. And many patterns of entrapment of the medial collateral ligament have been described. They are all rare. But the pattern that we will see is somewhat akin to a Stenner lesion, where we have a nubbin of tissue here, which could be portions of the meniscotibial ligament that have been torn, perhaps portions of the semimembranosus that have been damaged, but the medial collateral ligament seems to get stuck on something, and we try to characterize what it exactly is that it's entrapped on. But I think this is important to mention because it is not going to heal in the normal way. You can see that there's no medial collateral ligament below joint line. So the surgeons will sometimes refer to this as MCL at joint line when you see retraction like this, and it's just a much more prolonged course, or it may be reconstructed. Many of these patients have additional ligamentous injuries at the time of their trauma. Here's just another couple of examples of the MCL entrapped at joint line. In this case, it's stuck deep to the anterior arm of the semimembranosus. You can't always figure out what exactly it's stuck on, but we don't see any distal MCL. And in my experience, it's usually stuck inside the deep meniscotibial ligament that's been torn from the meniscus. These are the different causes of MCL entrapment that have been described in the literature. It may be trapped in the joint, which is usually after a knee dislocation. The ligament or periosteum can be trapped within physis that opens up in an adolescent, and I've illustrated some of the other structures on which it can get stuck. And there are distal forms of entrapment, and I do not have an example, but where it pulls up and then winds up resting superficial to the pes anserine tendons instead of deep to the pes anserine as it normally should, and then again will not be able to heal. In the distal MCL, injuries in this area are less common than in the more proximal portions. They do occur, and they will result in caliber changes, thickening, signal, the same type of findings that we have already discussed. The history of trauma, I think, is important when you're dealing with a distal injury because it can be very difficult on imaging to sort this out from pes anserine bursitis. The tendons of the pes anserine ride just superficial to the distal medial collateral ligament. So if there is pes anserine bursitis and a lot of inflammation there, you'll see fluid. You may see some reactive changes in the ligament below it. So the findings that are going to help you obviously are going to be the presence of history or valgus contusion in the bone, letting you know that there has been some sort of a traumatic event that has taken place. The MCL sprain versus pes anserine bursitis, we can see how similar they appear on MR imaging. The axial may also be helpful. We can see that the pes anserine tendons look entirely normal. The bursa should be a little bit more well-defined between the pes anserine tendons and the MCL, but the key finding here is that the only signal alterations that we have are in the MCL itself, which is thickened, whereas the tendons of the pes anserine appear normal. But it's not always easy to sort these out, so I think history, again, very, very important. Now, patients who've had MCL injury, as I mentioned earlier, despite the severity of the injury, are typically treated conservatively, at least as far as the medial soft tissues are concerned. So this is a patient at the time of acute trauma. You can see the extensive contusion on the lateral side of the articulation. The medial collateral ligament is completely disrupted all the way from front to back, and yet after some time, this ligament basically will heal spontaneously, and it is generally left with some thickening or irregularity that helps you recognize that there's been injury. Now, I always like to look for thickening on the axial views because the medial collateral ligament is oblique relative to the coronal imaging plane, and it becomes more oblique as you come near the insertion. And so sometimes you get some pseudo-thickening near the femoral insertion side. So it's worthwhile, if you're thinking it's chronic injury, to at least confirm that there is caliber alteration on the axial images as well. Here's another one. The insertion at the femur is thickened. In this case, we have some abnormal signal as well. And you can confirm that again by looking at the medial collateral ligament. It's normally only about 5 millimeters thick at this point, and in this case it's thickened, and in addition it's irregular with some signal alterations near that region. In some patients, when the medial collateral ligament tears, instead of just seeing ligament thickening, we may have additional findings that let us know that there's been injury, and that takes the form of ossification that is referred to as the Pellegrini-Stieda syndrome. Now, you'll notice that the ossification is quite variable. It may be in the ligament itself, but it's often seen at the distal femur. And the reason that we see this distal femoral periosteal elevation is that patients with medial collateral ligament injuries not infrequently will avulse the periosteum at the distal femur. So there is continuity between the medial collateral ligament and this distal femoral periosteal envelope. You'll often see edema tracking along the distal femur above where you would expect the medial collateral to run, and here we can see that the injury is propagated, and we have this Pellegrini-Stieda formation taking place in the distal femoral tissues, and this periosteal peeling was well described by James McNally a few years ago in skeletal radiology. Here's just another example. MCL extensively injured deep and superficial components, and you see this linear band adjacent to the femur superiorly representing this elevation. We may also see injuries in such patients to the adductor. You can follow the adductor down, and in very severe injuries, the injury can propagate into the gastrocnemius as well. All these structures insert very close to each other in this area, as I'll elucidate a little bit later. This patient had a very extensive injury and developed a chronic non-union of the medial collateral ligament. So in some patients, though this is rare, there is failure of healing of the medial collateral ligament spontaneously. And you can see this large fluid collection as she's leaking through the medial collateral ligament and its retinacular junction, lots of ossification and a big soft tissue mass, and then she required very extensive surgical reconstruction with a graft jacket for this chronic non-united medial collateral ligament, but an uncommon complication of MCL.